Many organizations have been doing important, innovative work in their local healthcare environments to try to alleviate and solve problems related to bias and discrimination in medicine. Racial disparities have been particularly profound in the areas of maternal and infant health. I'm Stephen Morrissey, managing editor of the New England Journal of Medicine, and I'm talking with Jessica Lewis, a research scientist at the Yale School of Medicine. Dr. Lewis has co-authored a perspective article about a group prenatal care program as part of the journal's series of brief case studies of anti-discrimination initiatives. Dr. Lewis, could you start by explaining the basic structure of the Expect With Me program?
Yes, absolutely. Expect With Me is a group model of prenatal care, which means that after the initial intake visit of prenatal care, at which there's a full private physical exam and psychosocial history is performed, patients are assigned to a prenatal care group with 8 to 12 other pregnant patients who are expected to all deliver their babies in the same month. The groups are co-led by a credentialed prenatal care provider, such as an obstetrician or a certified nurse midwife, and co-facilitated by an assistant who could be in a number of roles in the system: a medical assistant, a nurse, a nutritionist, a social worker. And each of the 10 group visits starts with a very brief individual checkups in the group space. Patients are engaged to take their own weight and blood pressure, and to log these on a HIPAA-secure IT platform so that they can track their own health metrics over time. The platform also allows them to communicate with their provider and other group members throughout their pregnancy through messaging and social media features, and access educational resources like videos and tip sheets on pregnancy topics. But the majority of time of group visits are spent in a facilitated discussion on the topics of pregnancy, focused on topics that we have found important in our research for the whole lifespan, things like nutrition and physical activity, mental health and stress, sexual health. And the Expect With Me program has a structured but flexible curriculum that focuses on setting and achieving health goals, discussing barriers and successes in reaching these goals with the support of providers and group members, and gaining and offering social support to practice those health behaviors. So it's a 2-hour-long visit as opposed to a maybe 10 to 15-minute visit in individual prenatal care. And that extended amount of time across a pregnancy ends up being 20 hours of prenatal care over a pregnancy rather than 2 hours in a traditional visit, which gives patients and providers a chance to really hear a lot about what patients are dealing with in their lives, what their struggles are in terms of achieving good health. And it allows a lot of social support during pregnancy. So it ends up being quite a different experience from individual prenatal care.
So, certainly I understand the additional time available with the group model. Why else did you think that a group model might be more effective than individual intervention?
The additional time is really important in terms of being able to get far more education during pregnancy than an individual visit allows. And also the patients are encouraged to do a lot of self-reflection and self-care to really help them think about taking charge of their own health and wellness. And the facilitative leadership style helps patients to recognize their own knowledge about their bodies and the community of other pregnant patients' knowledge about pregnancy as well. So, for example, if somebody has back pain in an individual pregnancy visit, they may ask their provider what to do about back pain and maybe get a handout about back pain and things to do. But in a facilitated group, the provider would throw it back to the group to say, who else has back pain here? And many hands go up. And now that patient is not going to be so worried that they show up at their emergency department, worried that the back pain is not a normal symptom of pregnancy, that it allows us to normalize the symptoms of pregnancy. And then would also ask the rest of the patients, well, what do you do about your back pain? And some might say that they do prenatal yoga. Some might take a walk. Some might take a bath. And so then patients start to see they have a lot of knowledge about their own bodies and can support one another with ideas as to how best to take care of themselves.
So you also talked about the digital component of the intervention. Why did you consider that important to include?
The technology really supports the connections that are built during the group sessions. We know from our research that among folks who are participating in Expect With Me, more use of the IT platform was actually associated with lower risk of low birth weight for their infants. And so the technology really is there to help patients feel connected between visits. So in the beginning, patients are being seen monthly in prenatal care. Later, it's every 2 weeks, but there's a lot of space in between to gain and support and also knowledge in terms of some of the educational components. We have tip sheets and videos on pregnancy topics as well.
In your article, you say that the Expect With Me program was tested at sites in Detroit, Nashville, and McAllen, Texas. Why did you choose those sites?
We wanted we wanted to reach a diverse pool of women. So those sites are different in terms of their patient makeup, and also to try to test it in a lot of different kinds of health systems. Every health system has their own challenges in terms of implementing a new model of prenatal care. A group model prenatal care requires quite a bit of restructuring of how sites decide to provide care. So it's really quite a leap from an individual experience, and sites really need to invest in how they put people into groups, how they schedule appointments, how they structure providers' time to allow for these group visits of 8 to 12 women in a time slot rather than one person after another. And so we wanted to make sure that we understood how it worked in different health systems with different populations.
And then do you have data yet to show effects of the program?
We do. We did analyses that we published previously that show that Expects With Me group prenatal care patients had a 58% lower risk of delivering an infant preterm, a 63% lower risk of delivering an infant with low birth weight, and a 36% lower risk of having an infant admitted to the neonatal intensive care unit than those receiving standard individual prenatal care.
Finally, is this model being used anywhere outside of research settings? How could it be applied in other health systems and in patient populations with various types of needs?
Absolutely. So we're in conversations with various health systems who are looking, especially those who are really looking to close the gap in disparities. There are very enormous and persistent disparities in birth outcomes between especially Black mothers and white mothers. And the latest data show that preterm birth is 15% among Black mothers in the US versus 9% among white mothers, low birth weight 15% versus 7%. And so for health systems that are really thinking about ways to close the gap in these disparities, innovative programs are really important. It's tricky because prenatal care often loses money for health systems, whereas NICUs are very lucrative for health systems. And in the absence of single payer systems or integrated health systems like Kaiser Permanente or Geisinger, we need more outcomes-based payment models in maternity that incentivize innovation, and we need more equity-based payment models that reward reductions in health disparities and allow innovative programs in this space.
Thank you, Dr. Lewis.